I don't know if you,
Go around.
some might know me or heard of me if it's only if it was good stuff. But my name's Keith Saunders. I'm Director of Finance and Operations for North Shore University Hospital as well as the Central Market as well. So nice to meet you all. I know a few of you. We just do for time, let's just do in the room, not online, but who's in the room? I know a few of you.
I know you know me, but I'm Annie. I'm the 9 Months evening ANM. We're on CSC together, so.
I'm Nellie. I'm the ANM for 7 Months and bone marrow transplant.
I'm Kimberly, ANM for 7 Tower.
I'm Cheryl. I'm the night A&M on 8 Monty.
I'm Crystal, the ANM on 2DSU.
Rob from Tuco and A&M.
Jeff, Tats,
ANM.
I'm Max from McHugh, Night A&M. And this is Angelina.
Yeah, no, that's fine. NSU, where you from? Which one?
No surgical. I'm medical ICU.
The MICU and then NSU. Nice. Okay. Nice to meet you guys.
We got a whole group online from various areas.
Great. Great.
Yep.
Nice to meet you all online too. I would ask, once I do different presentations like this throughout, through CLI, throughout the hospital, through the central region, I do lots of different ones. I do by myself and I co-teach different types of classes or discussions on whether corporate financial principles and modeling, staffing models, report trackers and what reports to use and how to do that. Some classes are very heavy into the math and calculations. Some are mostly more theoretical and conceptual. This is going to be mostly just talk a little bit just to keep it a little lively. Maybe you could use your phones and your calculator. There's some very simple, easy easy calculations just to get you started. The talk's geared to be about an hour. What I did was I took a presentation that I've given in the past. That was a 2-hour one. I chopped what I think is about an hour out and rearranged and added a few. We might skip a few slides. We'll see how the time goes. If you have questions relevant to the kind of information that I'm talking about, just blurt it out or raise your hand and stop me, and then we can talk from there, okay? You don't want to just hear me talk for an hour. I'd love to hear some of you talking as well. So today's topic, I want to focus this meeting mostly on, or primarily on, expenses. I don't want to get into reimbursement, although that's a really interesting one, but an hour topic's not enough for that. But I don't want to talk about gap analysis or accounting. We're going to talk about a little bit more what's relevant to the people online and to the people in the room, which is expense management, labor, supplies, hospital expenses, care hours, nursing ratios, and I forgot a word in here on number 4, inpatient floors, budgeting process, and timelines. I talked about this many months ago to the CSC committee and to the nursing managers. Some people are sometimes curious, like, what happens to the budget? Some people don't know what it is, or they don't see it, or they're just given it. Like, what happens? My office is right actually behind this wall. What happens behind the scenes, and how do I view as a finance person or financial leadership? What do I view as a nursing budget, and how do I handle that? We're going to talk about all that. Okay. So hospital expenses. Some of these are going to be a little quicker than others. So what do hospitals pay for? In general, it's very basic, but what are some things that the hospital pays for? Think like just real high level, nothing too in the weeds. Salaries, yeah, salaries is the big one. Materials.
Benefits.
Benefits on the salaries, yeah. Those are the biggest, actually.
Yeah.
What we're not going to talk about is capital. Capital is $2 billion for the health system. We're not going to speak about capital. That's a whole nother conversation for another day. But capital is the infrastructure, whether it's a computer, a chair, $500 million PSP building, a $100,000 MRI machine. That's capital. We're not going to speak about that, but that's a big thing. Here, we're talking about more of operating expenses. And you all hit on the big 3. Of course, it's a hospital. It's going to be labor and materials. With expenses, in its simplest term, without getting deep into accounting, there's generally controllable expenses in the hospital and there's non-controllable. We don't call it uncontrollable. We call it things that are not controlled within the hospital. Certain examples are, for an example, a controllable expense is something that's controlled or managed or restrained, where as department leaders, managers, assistant managers, even staff, when they open up supplies and use things, or in an OR where people just use stuff, they're making conscious decision to use supplies. Or salaries and wages, how do you manage? Do you, if you have a certain census and you need so many nurses, do you need all the nurses, or do you have too many based on census security? Can you float one out? Do you need an extra one? Can you call in per diem? Can you call in overtime if you need to? Do you float one in? You might say, oh, well, you know what? I'm short a nurse, but I had a CO that was called off. I have extra PCAs. It's not a heavy load tonight. We can get by. Those are really within your control to a certain degree. Examples are fees or salaries and wages, medical and surgical supplies, pharmacy supplies, bloods, all of those are controllable. There's also non-controllable expenses. Those are things that are beyond any of us. For example, depreciation of assets, for example, which could be in this hospital, could be a lot, like many tens of millions of dollars a year in depreciation because it's a big building over there. Interest. We pay interest on certain things. We borrow money, we pay interest, insurance, malpractice. There's a few other things that are beyond what we control, but it still hits our financial statements. It's still a very large expense to the hospital. What I'll mention briefly, but we're not going to get into, there's different components of expenses. There's direct expense, there's indirect expense, there's variable expense, there's fixed expense. I had a slide on that, but I chopped it because I don't want to get too heavy into that stuff. But there's ways to analyze costs. And I'm not an accountant, but I know some accounting. We look at that, and I work with the accountants because we have to put things into buckets. Is it directly related to patient care? That's direct. Is it variable? So as you have more patients, you use more cost, or is it fixed? These are different concepts, but not for tonight. Okay. All right, let's just blurt it out. Here's a question. How much of our, in general, it's a rule of thumb, it might be off by 5% or so, but how much of the hospital's total expenses do salaries and benefits account for? What do you think it's at? A low of 12%, high of 90%? Is it kind of in the middle, 25 to 76? What percent of a hospital's expense budget do you think is salaries? And this is relatively typical for most businesses. What do you all think?
60?
60?
60%?
C60, right. Whoops.
It is, okay.
60, whoopsie. 60%. So 60% of all expense in the hospital is salary. Now, how much I flashed really fast. That 60%, what do you think for this hospital? What do you think that number is for labor? So for salaries and wages and benefits, how much do you think that is for this hospital each year, roughly estimate? You can spit out, no, you can round it off to the nearest.
Is
number.
it cheating? I think I saw a billion.
That's fine, you can say it too.
$1 billion?
Right,
Yeah.
the billion, we're gonna get to that slide in a minute. And since I'm a day person, not a night, I'm a little slow, so I wasn't even supposed to hit this. You're supposed to guess it, but Ken, you didn't see that. How much of our total expenses do supplies account for? If you were to said 30%, you would have been correct. So the point is, between salary, you mentioned salaries and wages, you mentioned materials, somebody mentioned benefits, you hit the big three. Those account for about 90% of the whole hospital. Like what's left, that's 90% of it. $1 billion, about next year's salaries budget, only for this building. When I say this building, I mean for PSP, but for the hospital, I rounded it up to the nearest million. $1 billion and 19 million is what we spend in salaries and wages and fringe benefits. Fringe benefits usually fluctuates between 35 to 37% on top. So if somebody makes $100,000, the hospital's really paying about 136,000. That extra 36 goes towards all kinds of stuff, health insurance, retirement, and everything else. Next slide, which was also not supposed to be shown, supplies. If I were to say, how much do you think the supply budget is for next year, which includes some of the big ticket items like LVADs and implantables, which some of those are a few $100,000 each, blood and plasma and pharmaceuticals, some drugs could cost millions of dollars just for the one thing. We have just in this hospital, $500 million just in supplies. It's a huge number too. So between the billion and a half billion, it's almost $2 billion of expense. And when you add the other stuff in, it's about a little under $2 billion worth of annual expense at the hospital. Add that up, multiply it by all the hospitals in the health system, it's a lot, although by far, this is significantly by far, but combined bigger than maybe the next 10 or so combined, but it's a huge number. Let's talk just a little bit more about supplies and expenses. This is a typical breakout of supply utilization. You can see of, or all expense, I'm sorry, of all supplies and expenses. You can see that about roughly 50%, 47% is your salaries. But if you add another in green, you'll add the benefits, that's, 60-some% is your salaries and wages. The next percent you can see in the orange, that's your supplies piece, almost 30%. That 30%, you can see how much of that, if you split it out into different components, most of that is on the right, you see the 43%. Most of that is your basic variable direct cost medical surgical supplies, which would make sense. Anything that you use on the units in the ERs, labor and delivery, peri-op, procedural areas, consumable stuff that's used for the patients, that's the bulk of it. That's a few $100 million. The rest is purchase services, which are certain fees and certain contracts that we have. I mean, we spend many hundreds of thousands of dollars just on maintenance agreements, snow removal, electric. We pay for everything, the lights, the electricity, gas, electric, oil, everything, all that. And as time goes on, that with the tariffs and everything, just like our own wallets where things are getting tighter, it's tighter for the hospital too. Things are just more expensive, labor, supplies, revenues are a little lower. It's harder to get revenue. So sometimes your revenue is flat, revenue goes down a little, expense goes up, and you got to make sure you got to do your best where they don't crisscross. Otherwise, we're not making, we don't call it profit, we're nonprofit. For-profit hospitals are illegal in New York State, but we still need to make money so we can reinvest back into the hospital, into the health system, and to the community. Okay? That was brief. Like I said, I could talk for an hour on that, but quick stuff. FTEs, full-time equivalents. I would think most of you know what it is. If you don't, that's fine too. But who wants to say what is an FTE or a full-time equivalent? Anyone?
Position that is scheduled for 37.5 hours a week.
It could be.
Yeah.
You're on the right track. You're getting in the right track. A full-time equivalent FTE doesn't have to be full-time. You can be
Full-time.
part-time. You could work, let's say, 2 days a week. So that's like a 0.4 of a full-time equivalent. You could work, let's say, if you're a PCA, I work 3 days this week, 2 days next week, and then 3 and then 2 for a full schedule period. I work half the time, so I'm a half of an FTE, or I'm a 0.5 full-time equivalent. So there's always decimals. Per diems are considered, they're per diem, so they work as needed, and there's certain rules for per diems. But if you or your people, whoever does my experience, like if you were to put a position in or something, a per diem actually has an FT value on paper of 0.03 of a per diem. And I forgot why. There's a reason. It's more of an HR thing. I just can't remember. But that's what a per diem. Now, per diem might work, which they shouldn't. But some might work full time. Some might work 2, 3 days a week, 4 days a week, here and there. Maybe they work every other alternating weekend. They certainly work more than a 0.03, but they're valued on paper as a 0.03. So full-time equivalents. There's a couple different definitions. It's a work in my world, because a lot of stuff that I do is based on labor and productivity. It's a workload measurement, or what's called a labor productivity measurement, indicating basically a person's involvement in producing a service. In this building, the service is caring for the patient. Okay. The simplest way, there's a little nuances to that, but for the most part, it's caring for the patient. The number of hours worked or hired into the staff over a period of time is usually 7.5 hours a day. If I'm a PCA and I'm working 7 to 3, 3 to 11, 11 to 7, that's 8 hours, but I get that 30-minute unpaid meal break. So it's the shift is valued at 7.5 hours a day. If you're a nurse, you probably work, I know some areas maybe it's a 10-hour, 9.5 hour. The ER, dialysis, procedural areas have all kinds of different shifts. For the most part, though, the nurses 7A to 7:30 and 7P to 7:30 a.m. That's 12.5 hours. But the value of the shift, you take the 30 minutes out for the meal break, and then the 15 minutes, at least on paper, for the breaks. So a nursing shift is valued at 11.5. I had a slide in here, but I didn't want to complicate it. I took it out. Some people say, well, if calculations are based on 7.5 hours and a nurse is 11.5, and he or she is working maybe only 3 days for like 3 weeks and 4 days, which is called the 13th shift, and how does that all work? And it's
We did that a couple of sessions ago.
yeah, I did a few sessions ago where if you saw it, but I didn't want to get into it. It's smoothing because a nurse might work it, but they're paid something. They're paid like a little more. And then on the 13th shift, hopefully they work it. They're not supposed to take off. That's then underpaid to make up for it smoothing. So the FT value still works out. I had a calculation, but not tonight. So an FTE indicates how much, it could be full or part-time. And many times when I ask the question, people do think it's a full-timer, but it could be full-time, part-time, or per diem. So it's also how many people add up to a full-time. Like you might be a 0.5 and you're a 0.5 and you're a 1, you're a 0.2. And when I add it up, we would have a 2.2 FT or something. There might be 10 of us in here, but some might be part-time. I know we're not, but it might be 10 people, but 8 FTEs. So that's how an FT works. One important thing is an FT is not the same as a head count or a count of a person. For example, each of us, there's 2 people, but 0.5 to 0.5. It's different, but it is a calculation that's derived from a head count, from your daily staffing, and the little grid on the bottom kind of shows that. The daily staffing itself leads to certain numbers of worked hours over a period of time. I keep it simple saying work. I mean, technically, if you're calling sick, it's not a worked hour. If you take PTO or have a holiday that you're often paid, you're still paid for it probably, but whether it's time and a half or not overtime, it doesn't matter. You're still paid for it. But for here, I keep it very simple. Just it's what you're working or what you're hired into over a certain period of time. Okay. Those hours are converted to an FTE, and then FTEs are used for the reasons we mentioned. And this little box on the bottom kind of illustrates that, like on your unit at any given time or right before shift starts, yeah, you have a certain number of scheduled people on the shift, but depending on how many you truly need a few hours leading up to it, maybe we have to open 4 tower, or maybe we shut down 4 tower, or a surge area, maybe ED holdings. I know I was told never to use a Q word, but maybe you have less patients in ED holding at a certain time of the year and you could just shut it down. You flex up and down. It depends on the situation. It depends on the acuity. So I know some of the units might have your CSC guidelines. You might have your staffing matrices that are based on acuity and census. That's a guideline. It's not written in stone. It's just a guideline. That helps you determine how many people or the head count you need at any given time. Like if the census calls for a census, if tonight you're gonna have 30 patients on the unit, maybe you're gonna get two more, but maybe one or two will be discharged. If it was earlier, because maybe now things may be a little more settled in, you might say, oh, I would need 6 nurses, and I'm making it up, 3 PCAs as an example. That would be your staffing in that example. Then through your books or your communication, somehow you communicate to the staffing office, whoever your staffing person is, and those staffing office people, they log that information in that you tell them into Kronos, or it's just by the badge. Somebody badges in and maybe they badge out, it depends. They'll badge in and out, and that's communicated to the staffing office. Once payroll closes, I guess every 2 weeks on a Monday, when payroll closes, those hours all get in there, and then it interfaces automatically through the computer. It interfaces from Kronos or the UKG system into PeopleSoft, which is where all the financial reports are. In PeopleSoft, then there's many different types of reports in PeopleSoft, but in PeopleSoft, it then takes all the hours worked, and I can see by everyone's earnings, every dollar they've earned, what it costs. I can see all the detail. I can see the hours, and then the hours are then converted to an FTE. So you might have 4,000 hours for the week divided by 37.5 converts to X number of FTEs. That's kind of the process of headcount is being used to convert to FTE. Make sense? Let's talk about productive and non-productive hours. Different from benefits, PTO and benefit factor, non-productive time. Most people know it's different than benefits or fringe benefits, but I know one time I talked to somebody thought, or they were confused with non-productive time and fringe benefit. Fringe is different. We mentioned that before. That's like payment for insurance and all that other stuff that we get, all the benefits we get. Non-productive time is stuff that directly hits the paychecks, but not worked. So let's talk about productive hours first. Productive hours is just your normal basic working hours, whether it's regular time, overtime is productive but paid at time and a half. Holiday work time, depending on your level or your situation, you may or may not be compensated time and a half, depends on your title and all that. That's productive work time. Non-productive, this is the class, you're just here for an hour or so. We call it productive time because you're still working. If this was like an all-day class, then I would consider it on paper. It's you're being productive and listening, and actively listening, but it's not working towards the patient care to the bedside. So if it was a full day class, your Kronos person would tag this as education day or conference day or business conference, because it's not your normal job. It's considered non-productive time as it's related to your normal working time. Other things in non-productive time include orientation, training, paid time off is the big one, and holidays not worked. I guess next one is the Christmas time and New Year's Eve, and then the MLK Day, and these are all the big ones that are coming up in the future. That's the difference between productive and non-productive time. So if I'm making a 9 to 5 person, Monday through Friday, I paid 5 days a week. Out of 5 days, I'm a full-time one person and I'm a full-timer. If I took a vacation day on Friday, then I'm still paid 5 days. It's 4 days or a 0.8 productive or 30 hours productive and a 0.2 or a 7.5 hour non-productive PTO time. It's all coded into Kronos called pay codes or earning codes. Okay. So the standard hours at Northwell Health is 1,950 hours, which is really, if you just divide that by 26 weeks, because we're paid, I know there's exceptions, like flex are paid weekly and there's exceptions, but most of us are paid every 2 weeks. 1950 divided by 26 for the pay periods is 37.5 hours. Now, there are exceptions in some hospitals and some union environments. They work, it's a 35-hour week. Some have a 40-hour week. Another one has something else weird, but here at North Shore University Hospital, and most of the sites, it's paid at 37.5 hours or 19.50. Okay. Just take a drink break. So here's how the math works in its simplest form. Let's say you have a PCA, a full-timer, 19.50. That person works or is paid 7.5 hours a day for 5 days a week. It's just 7.5 times 5. That's 37.5 hours. Whatever number that is. 37.5. Then you multiply that number for 52 weeks. That's your 19.50. Now, if you were half the time, then you can just say 7.5 times 2.5 or 7.5 times 5 times 26. There's ways to do it, or this whole thing, if it's kind of like algebra, this whole thing divided by 2, there's different ways to get it. In its very simplest form, this is how an FT is calculated. It can get crazy and complicated, but for the class, for the most part, this is an FTE. I had already mentioned before, there's a little footnote about nurses and PCAs, about the meal break and all that, because in the past, I didn't have that, and people would raise their hand, what about the meal break and how's that work? It's accounted for, it's in here, okay? So let's talk about just one simple basic calculation. Another reason why we use FTs, it's to standardize how labor is measured. A lot of times I have to do surveys for the state or for Magnet or US News and World Report, AHA. There's so many different surveys. We're surveyed to death. There's so many surveys, or even within the hospitals or the health system. Sometimes human resources or quality or finance people need to compare. We always have to compare stuff. We have to have a way to level set it and compare. So we level set it based on using the FTE. How do we calculate the FTE? You can see in people at home or not here, you can hopefully see on the screen a few basic things. You need to first on the left determine the coverage that's needed. What do you need to cover? And we're going to get into the detail in a minute. And this goes back to those little color boxes that I showed. What do we need? Like basically, what do you need? How do we convert that then into hours? Then how do we convert those hours from people to hours and from hours to FTs? So you need to know your standard. Is it a 1950? Yes, for here. Is it for the day? Is it for the week? Half a year is 1975. Is it 1950? What is it? Last year was leap year. How does leap year fall into it? You don't have to know that, but these are things that I have to think about, leap year and all that other stuff. Then we have to remember doing that. If you stop there, that's just your work time, your base FTE, your productive FTE. You have to still add non-productive time onto that. What happens if you don't add, if you come up with a calculation saying, I need this many people and it's going to cost this much and this is what I need to run the unit and staff the unit. What happens if you forget to add non-productive time? Anyone want to say?
Short.
Well, you have the potential to run short. We probably wouldn't do that. So you're probably going to have,
You would need to back.
first of
up.
all, you wouldn't miss it because there's people like me that would watch it, make sure you don't miss it. But if you miss it, then you're going to run short. You don't have enough staff. You don't have enough coverage to let people off. But of course you have to. So we're going to have to call in flex or just over hire because somebody goofed and didn't see it. You're going to have to bring in per diems or float or something to cover that, or you run short. One of all the above. Hopefully it's not short. What else do you have to consider when we calculate an FTE? Replacement factor, non-productive time. That's based on the simplest way to explain it. That's based on historical averages. Generally, in general, it changes throughout the year, but in general, when I do a budget, I budget nurses at 18.5%, everyone else at 16.5%. Areas that have fellowship like peri-op, emergency room, critical care, I usually budget them higher at maybe 22 to 23%, because on top of the normal 18.5%, you got to dump 5, 6, 7, 8% on top to allow for all this 6 to 9 months of fellowship time. Okay,
Can I ask a question?
sure.
Maybe, I don't wanna interrupt the whole presentation.
That's fine.
As far as Epic goes, like Epic training, right? Because that's gonna be non-productive time.
Mhm.
How do you calculate that for like the whole hospital? Is it just based on like the number of hours, the number of classes that people have to go to, and then incorporating that in
Yes,
the calculation? Okay,
in the simplest way, yes.
okay.
But it gets tricky and we have special budgets for that. But behind the scenes, we have special budgets and we're gonna have to bring in staff. It's not gonna be messy, but there's stuff that's happening behind the scenes to make it as smooth as we're able to, but that stuff is thought about. It's considered.
Mhm.
Not perfectly, but it's considered, yeah. Good, but that's a good question because you're thinking ahead. So let's do a sample problem. Let's say you have to staff 5 operating rooms with 2 team members from 7 in the morning to 7:30 at night, Monday through Friday. Assume you have a 20% non-productive time. It's an assumption based on historical averages. How many FTEs would you hire? We don't have the time to actually calculate this one, but we can go through the steps on the right. Remember, the first thing is just, what's the coverage needed? Well, we said, well, we have 5 ORs, so we have to cover 5 ORs. We know that the time is from 7A to 7:30 P, that's 12 and a half hours. But remember, we have to back out the meal break, so that's 11 and a half hours. So each OR is gonna have 11 and a half hours. But we also have 2 people, so then you have to double that. So you see this on the right, the second table, it's 11 and a half hours a day for, and we said it's only Monday through Friday, it's 5 days a week. 11 and a half hours a day for 5 days a week, doubled for 2 people. That means we need 115 hours to staff to cover this. But that's only for 1 OR. We want it for 5, so then you have to multiply it by 5. We need 575 hours of people to cover it. So this goes back before, you have the head count, you need 2 people at all times, each one, converted to hours, that's 575. Because it's 1 week, it's 575 divided by 37 and a half hours, which is your base hours for the week. We would actually need to hire 15.33. Sometimes people might say, sometimes they'll say, can we round it to 15 and a half? Or I just need 15. We'll just throw in the 0.33 as overtime or something. Sometimes we bump to 16. It depends on the situation. But mathematically, we need 15.3 FTEs of productive time. If you leave it there, you're done, you run short, to your point. We have to add 20% on top of that. Most people say it's 15.33 times 1.2, 20%. That's wrong. We're not gonna get into why, but it's incorrect. It's the worked hours divided by the productive time. So 15.33 divided by, in this example, if the non-productive time is 0.2 out of 100%, then the productive time is 80%. Or you see the little formula, 1 minus 0.2, about 80%. We're not going to get into why it's that, not 1.2. Just got to trust me on it. So you would need to hire almost 20 people. Now you might have 20 full-timers. You might have so many part-timers versus full-time. This is something that's based on what you feel works best for your unit. You can ask a colleague. You can ask Palmetto Zamova, who's the manager of the staffing office, or senior manager, Pat Herman, one of them to kind of help you to figure out, or you might just have a knowledge saying, I know I need X number of full-time and part-time to do that. That's something you do what you want. I'm good with that as a finance person, as long as you stay within 19.1. If you're under, I'm fine with that. Under saves money, but I realize penny wise, pound foolish. We have to be careful. If you're too far under, then what's happening to staff burnout? What's happening to quality of care? I think about that too. Or maybe if you're under because maybe something happened and we shut down an OR, or maybe you're over because we extended hours. There's reasons to go up and down, and that's where we'd have what's called conversations, variance conversations. Okay, let's turn to care hour. Whoops, might have double hit it. No. A care hour and a ratio. To calculate a budgeted care hour, I'm assuming people know what care hour is. It's on average over the course of 24 hours, how many hours of direct nursing care does each patient on your unit receive in general? Okay, that's a care hour. And a ratio, you probably know what that is. If I have, how many nurses or how many patients are assigned to each nurse? And there's care hours for PCAs and all that other stuff, but we'll focus more on nurses. The total number of base FTEs, I'm sorry, to calculate the budgeted care hour, you need to know a few things. You have to know what's the total number of headcount converted to hours, converted to FTEs of your base, like before the 15.33. The total number of hours worked, because you got to know the conversion, 1950. And you also have to know your patient days, which is the sum of each day's average daily census or each day's patient count census on the unit over a period of time. So if you have 30 patients today and you have 30 tomorrow, could be the same, it could be different patients. Between the 2 days now, you have 60 patient days. If the next day you have 25 more, that's 85 patient days in 3 days. But if I say, well, over the last 3 days, what's your average daily census? It's 85 divided by 3, which is probably whatever, whatever that number is. That's how you calculate a care hour. Base FTEs times 1950 divided by patient days, okay? Now I'm going a little quick just because of the time. Let's try to do a quick calculation, even though I did this really fast. If you want to get your phone out. Here's an assumption. Let's say you have a bed capacity of 25, okay? Your percent, we're assuming a budgeted percent occupancy of 80%. We're also going to assume that you're going to staff 4 nurses just 24/7 around the clock, 4 nurses at all times. And on other classes, I say, let's calculate what's your worked FTE. We're not going to do that here. I just did it and said your worked RN FTE, when you do all the math, is 17.17 FTEs. And assume you have a non-productive time of 18%, okay? So what's the base FTE? What's the ratio? And what's the worked RN care hour? I'll give you just a moment and we can talk about it and then we can just go through it. I kept it semi-simple, but maybe it's not. I think it's simple just because I've been doing this for 30 years, but I couldn't do any of your jobs for 30 seconds before I was caught as a fraud, so. So I take it for granted that I've been doing this literally for decades. Does anyone, I know it's fast, but does anyone, let's do the first, well, what's the base FTE? Does anyone know what the base FTE is? And if you don't, that's fine too. If you remember, when I went back. Oops. Oh, this doesn't go backwards.
It does, you gotta keep it in the left arrows.
If you remember, I said before, the base FTE is your worked productive FTE. So your base FTE is kind of, the answer is here. Your base FTE is semi-trick question. Your base FTE is your worked FTE. So your base FTE is 17.17. I heard a few people say that. What's the ratio? Now, this one, there's a teeny little trick in this, but what's the ratio, the nurse to patient ratio on this unit? In this example,
If you're at 80% occupancy, it's 1 to 5. You have 4
Right.
RNs at all times.
perfect, yeah, that's great. Because if the bed capacity is 25, but the occupancy is only 80% of that, so we're budgeting for 20. And if we said we have 4 at all times, it's just 20 divided by 4, right? So that's great. It's a 1 to 5 ratio. Each nurse has 5 patients. The trickier one, because now you have to put everything together, what's the worked care hour? That one's a little trickier.
20.94.
Hmm.
20.94.
Okay.
Or just embarrass myself.
No, you didn't embarrass yourself.
Because
I'm
we
glad,
have to
I'm gonna
insert the
give you an A
percentage,
plus,
right?
I'm gonna give you an A+ for trying.
Okay.
It wasn't right, but you tried, so
Alright,
that's,
fair enough.
that's,
Job, Annie.
that's good enough. I'll show you, and that's okay to get it right, it's fine. I'll show you. If it goes, hold on. What's the base FT? 17, the ratio. The trickier one is the work care. The worked care hour is 4.59, meaning each of those 20 patients on average receives roughly 4 hours and then a 0.59 hour. Everything's based on 60 minutes, so if that's at 4.5, it's 4 hours and a half. How do we get that? There's a couple ways to do the calculations.
Okay. yeah.
This is how we do
Calculated
it.
the wrong way.
Remember, we take the care
I
hour
did the
before.
FTEs with the non-productive time.
Yeah. So when I said before, I had it with the thing, I said it's the work care hour budget is the base FTE. You need to know your base FTE, that's 17.17. You have to know your standard hours, 1950. So it's base times 1950. It's 33,482 worked hours of productive time. Okay? Out, and the care hour is that divided by patient days. Remember, I said if it's so many days each day, so if it's 20 patients annually, if it's 20 a day, I could have said on last year, and then hopefully it'd be like, oh, last year's trick question, that was a leap year, it's time 366. It's this year, so it's 20 patients times 365 is 7,300 patient days. And when you do the math, the care hour is 4.59. Just a quick and dirty method to come up with the ratio. If you just take, if a nurse's shift is 11 and a half hours days, 11 and a half hours night, that's 23 hours for the clock.
Yeah.
If you take 23 divided by the care hour, it's 5. That's a quick way to come up with the math. Make sense so far?
Yeah.
Okay. We're gonna spend the last section. We have, I know it's 10:54. Hopefully we can spend 10 minutes on this.
Started later.
This one, maybe you find, equally interesting or more interesting. This is more words now, no math. This is kind of what I do and what happens behind the scenes during the budget process. And this is the timeline for a nursing budget, okay? What I'm talking about is just general. It's usually this way, but it doesn't have to be this way. But for the most part, this kind of happens like this. Sort of around April or May, kind of in that area. It's a gray area there. April or May, I start gathering my stuff, all my materials, my information, my data. I start looking at it. I start looking at trend. I mean, I do this every day. This is my job, but I really get into this stuff April, May. I start really thinking about next year. We actually, as finance people in February, we actually start preliminarily, it's insane. We start thinking about next year's budget already in February, which is nuts. But for nursing, we really start getting a little bit into the weeds early spring. We analyze data, we look at trends, we start building preliminary staffing plans, just basics, very basic stuff. Just it's kind of comes into my mind, I start thinking about it. And then anywhere between June and August, the big health system, historically Maureen White, now, and then combination for the last couple of years, Maureen and Lynette Wolford. Now it'll be Lynette, unless Maureen wants to go back as a guest, but Lynette or Maureen would meet sometime late spring into the midsummer. She'll meet with each chief nursing officer, and I say designated others, always me. Usually, the CFO, Ryan Anderson, all the senior directors, like Michelle would be there, for example, Josephine Buck Jones, Cindy Gomez, different people would be there, whoever Tara or the CNO would choose to bring there to talk about the budget. We're going to get into that in a minute. What happens at that meeting with Maureen? It's a comprehensive review. Years ago, it used to be a 5-hour meeting. Really, it should be about a 2.5 to 3 hour, but she only schedules 2. It's never enough. We run out of time, and then we either rush it and we have to reschedule another 2. But it used to be a 5-hour meeting, which is really long. It's usually a 2 to 3 hour meeting of a comprehensive review to demonstrate to Maureen the knowledge and understanding we, like the nursing, I don't talk too much, my job's, I bring them to the table and then say, you got what you need, I've got you to the Super Bowl now, put it over the line. It's really Tara and the directors speaking about defending their budgets and talking about their units in painstaking detail. Sometimes it's a 5-minute talk, sometimes it takes 25 minutes for the certain complicated areas, like ICUs or maybe for bone marrow, certain areas that have a lot of complexity and different things going on, or transplant areas. These are areas that we talk about, or Tara and the directors talk about to defend their budget. That's what happens there. What do we talk about at that meeting? We talk about a lot of stuff, our feelings, our thoughts. When I say us, it's them, that not, I don't talk about it. It's more of a clinical conversation. But what's discussed is volume. What the volume was, what the volume is, and what the expectation. It's always before, current, and forward. What's the volume? What are our ratios? What are our care hours? We look at turnover rates, we look at vacancy rates, we look at retention, we look at mobility, we look at leaves of absence, we look at basically everything. We do look at quality metrics as well. We look at that. Float pool resources, premium labor, meaning flex staff, overtime, and we look at per diem's not premium, but it's supplemental resources. We look at constant observation and video monitoring now, and what's the other way? SRO, which used to be the enhanced supervision, supervised room observation. We look at all this plus more stuff to talk about the budget. What was it in the past? What do we have now? How might it change in the future? And if it changes, why? And why do we think it's going to change for the better or for the worse? These are things that we talk about. We talk about spans of control, table of organizations, quality match, case mix index, CMI, meaning in its most simplest terms, how sick are the patients? What's the acuity of a patient? CMI is more of a financial measure on how sick they are. But Maureen says, what's your CMI in this and that? Do you know what it is for South Shore or Lennox or LHA comparison? We have all that. All you guys have the books, the big books that I put together on this stuff. What's your non-productive time? Within the non-productive time, how much of that is planned versus unplanned, or scheduled versus unscheduled? How much of that's orientation time? What percent of that's PTO time? Do you know your sick rates, for example? Oh, why does this unit have such a high sick call rate or a high turnover rate? Or what's your nurse retention? What's your first year nurse retention? What are you doing? And then we might veer off and get on a whole different path talking about some of the ugly stuff or the great stuff that's working, and what have we done because we're doing wonderful on certain things, and what are our initiatives. All the good stuff that we're doing in the hospitals discussed. Expected changes to the staffing next year or to the units next year. All of this stuff is talked about and planned for her meeting, and that literally takes me almost every day for months just to get to that point. It literally reminds me like football, preparing each thing. It just takes so long to get to that point. Let's turn our attention, a little hard to see unless you're close. Real fast, we're only going to spend 30 seconds on this. This is what a staffing grid looks like. We put together a staffing grid. And I apologize for going so fast. A staffing grid on the top. We talk about these are the basics. We talk about the bed capacity, the percent occupancy or the average daily census, non-productive times, ratios, FTEs, care hours, all that stuff's on the top right. We talk about what you're not seeing on the bottom is there's a whole thing with all kinds of metrics, whatever the metric or unit of service is for your unit, whatever is pertinent to discuss for your unit. There's a whole big giant paragraphs and tables of data for each person, a whole data sheet to help to get to this point. And in this example, we're saying this unit, to budget 39 census, we would need, in this example, we said we needed 8 nurses basically at all times. However, we came up with that, or Tara came up with that with her directors, we came up with that. PCAs, I guess we said 554, 554. Maureen might say, why is it this? Why is it that? Why do you need 4 at night? Maybe because they're not ambulating, they're sleeping. Well, can't you have, how about 443? oh, no, we need 5. That's up to Tara directors from a clinical quality point of view to explain and justify why they need that. There's all kinds of math in here that we're not doing, but you can see on the bottom, there's comparisons. Last year, when I did this presentation was done like last year, so really it was last year and then what's next year's budget. So what was 24, what's 25? This year when I do, if I updated this, it would have shown 25 and then next year. You can see there's all kinds of comparisons. This is really what a staffing grid looks like. And this helps me to get to my next step, which I'll show you. Oh, the staffing grid, it's based on current and expected average daily census and acuity averages. Everything in finance is based on averages. Sometimes director might talk to Lynette or Maureen, they say, you're going to extremes. I know in worst case, this might happen, but don't talk like the worst case where you need like the highest level of care, the most staff. And I know the screen might have blacked out, just bear with us. We also look at, and I know some people don't think I do, but I look at weekends versus weekdays. How does a Monday, Friday census pattern look compared to a Saturday, Sunday? I'll look at day and night. I know some units sometimes have more patients later at night than they do in the morning, maybe a surgical area. I'll look at maybe a Monday, the surgery schedule's big Monday, Tuesday, Wednesday, and it starts getting quiet, and by Saturday, Sunday it ends. If it's a CSSU unit, I know, for example, it's around the clock, and then Saturday into the afternoon, patients leave, and then it's closed by mid-afternoon Saturday, closed Sunday, reopens again Monday morning. These are staffing patterns that we have to consider, okay? You're not seeing it, but I can just talk through it. After Maureen completes the system-wide review, after she does all the hospital, she'll give her recommendations to Mark Salazzo, now Kevin Biner. She'll give it to Frank Rizzo, who's the senior VP and CFO for the region. She'll give it to all the regional CFOs, me, Ryan Anderson, the CFO, Tara. She'll give her recommendations to them on what she feels. We might say something, she can agree or disagree. You know, we respect each other's opinions, agree or disagree. We take it as a recommendation. We can implement it or not implement it, but if we choose not to, we have to explain why we're going in a different direction. Because at the end, it's still, she said, it's your hospital. This is, from my point of view, this is what I recommend based on what you've told me, but it's your hospital, your decision. You have to live by your decisions. Basically, that's how it works. So then in August, in general, I usually prepare the official budget. And I do a lot of regional work too, but this is only conversation for nursing. In August, I do the regional budget, and that takes a few weeks to do, where it's a lot of key punching and stuff like that. And again, I'm skipping all of this. I'm spending 15 minutes talking about. This takes months and months. Like I said, our information that we put in can differ from what even Tara had. Some of it can differ even from what Tara and the directors had talked about back in May and June. Some of the reasons because of labor trends, things that when we talked in June, no, when we met in June, we had to base it on May data because it was so old. But by the time August comes, I already have 3 or 4 months worth of data. So we have a lot more data that could change things for the better, or I don't want to say for the worse, but it can just change things up or down. We have better information now. We have more months of acuity. We have more months of volume. We have more procedural trends. Just more time has happened to know something, and any other new knowledge we might have. So lots of things are going on by August. Then from September to what I call mid-flash, the budget presentation to all the high-level people happens always mid-up. It's usually the third week. It's always the third week of October. So from September to mid-October, budgets are always being modified, tweaked, last-minute things are happening by the site, by the region. Margin means profit. Margin expectations come out saying, you know, the system, I'm making up, the system is, you know, the health system predicts we're going to be short $250 million, and 175 million of it is the central region and North Shore, the big hospital is 80 million of that. Either figure out efficient, painless ways to reduce expense or smart ways to increase revenue. It's a mix of both. That could happen. Excess, we think about excess days, we think about readmissions, all these things we kind of think about and work into the budget. And other things happen. So that's what happens once we go September to October. Once October hits, and sometimes you have to go back to the drawing board a little bit, just a little bit here and there. They might say, well, this is good, but I think this is light here, or this is too much here. This is conversations between Mark Salazar, the top level people and the sites saying, I think you do this, do this. We'll come back, and then finally what happens once that's approved, me and my boss have to do what's called spreading the budget, allocating the budget. And that's literally happening right now, like last week, this week, as we speak. My boss spreads the revenue and the discharges. We have $2 billion worth of revenue and $5,000 worth of 55,000 discharges and emergency room and deliveries. And we have all of this units of service. He has to figure it out, is it divided by 365, divided by 12, is it quarterly? How do you spread that? He deals with that, and that's a whole nother course to talk about. My job and my role is to spread the FTEs. Do I just take the 5,500 FTEs or the 1,400 that are in nursing, just everything divided by 365, or how do I do it? And I have to follow patterns of volume, and some of it's guesswork. But I have 30 years worth of experience guessing, so my guesswork's pretty good. Some of it is based on, historical models. It's not just guesswork, but it's guesswork based on, good information and objective opinions and math. I have to spread FTs. I have to look at flex time use. I have to look at overtime. I have to look at summer interns, nurse externs. I have to look at, for example, right now, I think there's roughly 15 people of externs. Right now, those 15 people, if you do all the math, that comes out to be maybe 4 FTEs when you just figure out the math. Right now, finance just has 4 FTEs spread across 365 days. That's wrong, because what would happen if we do that is each month we're going to have a budget of 4, an actual 0, a positive variance, meaning we're ahead by 4. We might be like, oh, we're good, we're 4. But then what happens in June, we're still budgeted 4, but now 15 start. Now they're like, what happened? You were favorable. All of a sudden now you're over budget. It's because we didn't allocate the resources appropriately. So I have to make sure I zero everything out, take 0, and then once it hits mid-June, I have to budget 15 for 8 weeks and then 0 it again. That's just one simple example. I have to work with corporate finance and work on patient days. What's this patient days look like? What does a non-productive time look like? All that stuff happens now, but for the last 3 weeks, it's going to happen for the next couple weeks again. So between now and into January, I fine tune things. I negotiate. We have the care hours, we have the ratios. I haven't released them yet because I'm still tweaking and fine tuning them a little bit, moving things around. We can't change the bottom line, but I was just talking to a director today. A little bit of a model's changing on something, so I have to move. It's like that little game with the pieces. The bottom line picture won't change, but the detail's going to change. So I'm still doing a couple budget changes as long as the bottom line doesn't change, because we're locked for the year. We can't change. Only if the budget doesn't change, but we do what's called post-budget approved positions. So for example, if we add more resources, we have a new program and we have to add 10 more staff, for example, we'll add the 10 staff in. We have reason to do that. It's over budget, but it's explained. That's something different. That's called a post-budget position. We make sure that we just get it the next time. December and January, it's a little late, but I know it really should be done now, but it's the best I can do because of everything. Staffing matrices, what I mentioned before, those are prepared. Those are sent back and forth to me and the directors. They'll do it. I'll tweak it a little bit based on what I think is it has to be within budget. If it's over budget, I can't accept it. If it's too far under, then they're shortchanging themselves. So I tweak it a little bit. I give it to Tara. She'll give her opinion. If I'm cool with it and we're good with it, then I just send it to the directors and it goes in your staffing books, it goes on your wall, and it goes into the, and we're gonna finish in about a minute. It goes into the staffing office binders. CSC stuff's prepared probably, which is based on minimum staffing, different from this stuff, but we look at this when we do the CSC. That's a separate thing, but that's all done in April, May, and then that's entered in July, but that's another thing. So the matrices are sent out and that's used as a guide, and by then you're already into January, and my job now is basically monitoring everything, talking to people, meeting with people, and literally 2, 3, 4 months in, back again. And that's it. I know I sped up a lot, but wanted to keep it, I don't know if it was fun, but a little lively. Any questions before we shut down? Any questions on anything you're curious about?
I have a question on like, judging the acuity. So you were saying the CMI is the acuity? Is that what you were
It's-
saying?
It's a different, I use the word, it's acuity, but it's not, it's used in a different way than on the nursing, as you would, as a nurse or, as a clinician and a manager uses acuity. CMI is a complicated way that CMS and Medicare groups and buckets, payment models like DRG, diagnostic related groups, the way they classify certain cases. It's a case mix index weight. It gets very complicated. It's related. It's not acuity. I say acuity, keep it simple. It's related to acuity, and a unit like a MICU or IC, MICUs, NSCUs, CTUs, they have high acuity.
Mhm.
Therefore, they're directionally, their CMI case mix index would be high. An area that's just your typical just med surge, somebody's here for 2, 3 days, they go home. They're gonna have relatively low acuity. That's why in an ICU, you might have one-to-one staffing, maybe 2 nurses for, maybe 2 patients for 1 nurse, 1 for 1 nurse. Sometimes, I guess, if you're doing ECMO, you might have 2 nurses for 1 patient for the first day. So that's really high care hour, low ratios, high acuity, high CMI. We're also paid and reimbursed a lot more for that. Other areas, we might have a 1-to-5 ratio, 1-to-6 ratio. The acuity is low, the CMI would be low, because the CMI is a measure of the intensity of resources put forth to that. And it's a simple way of explaining it.
And we would show that just like on the care hours when we're updating it, like showing like what our,
CMI or acuity?
like the acuity, like
No,
that's
the-
the only way we would be able to.
We don't have,
identify
the only
our-
way, like, for like nursing.
Mhm.
I have CMI information with accounting, and there's ways that I can get it. There's a whole mathematical calculation to calculate that. Acuity, we don't have like a number for acuity. Basically, Tara or your director would have to ask you for certain data and examples of reasons why you might have patients that require certain levels of staffing or certain levels of care. Like in I don't have my book in front of me and I'm not a clinical person, but in the ICU, they might have a whole list of things that they measure regularly or just when it's asked for, of things that they explain why staffing is the way it is, or why the staffing was high. Like the CTU does a nice thing every month. They send me an acuity tool saying, this is why we had more staff and we were over budget, because maybe our census was 19 instead of the budget of 20, but we had 5 more nurses because the acuity was high. We don't have a real great acuity classification system that gives you a real number. Maybe with Epic we will, I don't know, but that you would give me, or that acuity tool gives me reasons why acuity could be high, like numbers of LVADs and ECMOs and whatever else all the clinical stuff is to explain why acuity would be high. So it's more, it's data driven, but it's all supported and given by, self-reported by the units. Sure. Any other questions about care hours, FTEs, budgets? Anything before we wrap up?
I guess piggybacking off of that, is there any type of like system that exists, I think it's really hard, like quantifying acuity because it can be so subjective, like
Yeah,
depending on what facility you work at, policies are different based on corrective actions that you've had to put in place and why you're doing certain things the way you are. But like nationally, is there any type of acuity tool aside from CMI that like also calculates like more nursing driven things? Like
There
how
are.
long does it take to do this particular nursing care initiative, and on average,
I
how
think
much are
you
you
guys
doing
might
that
have a
in?
better.
Yeah, there are acuity tools out there, it's just not one that's been adopted. I mean, is anyone perfect? No, maybe we should do that and then,
I even worked, I've been here for a long time, 20 years. And I used to work at Mount Sinai a long time ago though, but even when I was at Sinai, it always came up with acute, like even then, we didn't have, we never had a good acute, so maybe that's just a thing, we don't have
Yeah.
a good
Cause I
classification.
even know, like, I know like DRGs are used and, there's a lot that goes into CMI that like, is not necessarily about,
Yeah,
it's about diagnoses, it's not about like
No, I
what
get
care
it.
you provide to those diagnoses.
it's related, but it is different, you don't get into all the detail,
Like
which is
into
why
the weeds, yeah.
we have to ask like you guys, like, to self-report certain things. These are things, I'm not a clinical person, so basically when the budget comes out, I leave it blank and I tell the director saying, fill in, the 4, 5, 6, 7, 8 things that you feel are things that should be monitoring and considered why staffing is the way it is.
Mhm.
And that's basically me saying, what's your acuity, but what impacts your acuity. And it's unit specific. If there's 25 units, there's 25 different metrics. Many of you have the same metrics, but some of them are very specific to the patient population on your floor.
Mhm.
Anything else about anything? Anything you're curious, surprised about? Yeah.
Curious, just if nurses like leave and go somewhere else, what determines like when you're able to hire to replace them, like budget wise?
Are you talking about backfilling a
I
position?
guess like when you can backfill the position, like what determines how long it takes to like open up the position to replace them?
Yeah, I was hoping,
Go ahead.
oh, man,
Oh, ran out of time.
You're not getting out of that one.
it's 11:20. That's a complicated one. Are you asking because you're curious or because things have been faster or slower than it's been, or you're just,
Like
you're just wondering in general?
combination, I guess, cause we had a couple of nurses leave and then they're like, oh, you don't have the budget yet, and I'm like, okay, like, I'm not fighting it.
I can
I'm
tell you
just curious.
I can, without getting to specifics, I can just give you in general, I now putting target on me, but I approve all the positions in the whole hospital.
Oh, it was you.
But not just for nurses, but the hospital, but it's just not me on my own, I coordinate with the corridor. I coordinate with Tara and Andrea and Will everyone in the corridor and work. It's been a little more tight this year, particularly since July, only because revenue has been shrinking, expenses have been going through the roof. And we need to get in a simple way, we need to get a better handle on the care. I don't know if you see your nursing monitor, if you look at the cover page, the total paid care, in general, it's actually last pay period, it was actually one of the best it's been in a really, really long time. But for the most part, the care hour has been through the roof, real high. I mean, yeah, we can get into conversations where somebody's like, well, the budget of care is too low and these are the reasons why, but budget is locked. It is what it is. That's what we agreed to. We have to stick with a total paid, a total RN direct worked care hour. We're really high. And when you do the math and figure out the math, that equates to so many FTEs. If I take the care, you saw it before, if I take the care hour times the census and convert it, that is so many FTEs. We need to make margin. Our margin, our margin is slipping. So to maintain the margin in the health system, we had to better manage the position. So we've been more strategic on backfilling in the past. Anytime a position would come up, almost immediately, within a day or so, I would approve it. But lately meaning since July, we've been way slower. We've been bashing them together. It's been more strategic. Just because you had a person and they worked and now they're gone, doesn't necessarily mean we're going to open it as soon as you would like to. We had to get a better handle on the budget. we had to get a better handle on, because around July is when things slowed. If you saw my timeline, that's because that's around the time we're doing budget. We started to see our expense targets or revenue targets. We were many hundreds and hundreds of millions of dollars away from that. You either decrease expense or increase revenue. Now you can only decrease so much expense. You can only get so much revenue. So to better manage that, we were slower to approve. When I say me, but it's not just me, you know, I'm a spokesperson for the hospital. We, plus makes me feel better, say we had to better manage the positions to try to get the care hour more in line to the budget. But we do realize, you know, at some point, you gotta be careful too, because, you know, you don't wanna overly upset people, you don't want it to impact quality of care, you don't want a lot of turnover to come. We do realize that the holidays are coming, flu season's coming, RSV's coming. To your point, tons of people are going on Epic training, fellowship starting. We're aware of all this stuff. You know, I'm aware of it all. And the good news is, I don't know if Tara's talked to people. The good news is, we finally loosened, and we haven't frozen it. We've not frozen positions. We're not hiring, but if you read in the papers, across the country, many health systems are downsizing. Tons and tons of clinicians and people are losing their jobs. It's being frozen everywhere, all over the place. It's much better at Northwell, for real, and North Shore University Hospital. It's much better than most hospitals in the country. Because we're doing an excellent job. You guys, not just me, all of us, we're doing a great job of managing our resources, an excellent job of managing premium labor. We're barely using flex staff. Our overtime is really low. We're doing a great job managing premium labor. Because of that, things are loosening up a little. Fortunately, just a week ago, I approved about 110, finally about 110 positions in nursing alone. Not all were nurses, but tons were nurses, lots were float pool, lots were critical care, lots were scattered throughout you guys' areas. CSA is monitoring techs. There's a few ANMs that are vacant. We're filling those. PCAs. There's a lot of stuff. We finally it takes time though. Now that I've approved about 105 or so recs, it takes time. I had to call recruitment to say, guess what? You're gonna be bombarded with a ton of recs over the next 2 weeks. I might approve it yesterday, but it takes, I don't know if you know, like the secretary, like Brian Murphy and Rosa Barrows and Barbara Bowman, those June says those ladies downstairs, they have to enter it all. It goes into the system. Mary Beth Wexler has to approve it in my experience. A rep gets on it. It takes time for them to get it. You guys interview. It takes a long time. So I know it's been probably a little challenging for months, maybe even frustrating, but it's hopefully going to get better because now it's going to take a few months by the time they start to come in. But finally, you know, we've opened up a ton of recs. Every Monday I send Tara a list of pending positions, meaning positions that are in my queue for approval. I can't sign off. It's a little more micromanaged in the last few months than it used to be. I would just make my own objective decision and sign off. Now the CFO has to written approve it. Even if Tara says, or anyone in the corridor says, I spoke to Ryan and he says we're good to go, I'll still go and talk to him because I want to make sure, 'cause sometimes sometimes it's not as obvious as what I was told. So I'll just say, are you good with this? I heard you approved 5 FTs, or are you cool with it doing, you know, signing through 50 nurses? You good with that? And he might say, no, I didn't say 50, I said 40. If this it depends on what was said, and then I'll approve it immediately. So that's kind of the reason why I can't really say how long does it take.
Yeah.
It all depends on the circumstances of care hours, ratios, budget, FTEs, where we are with our FTEs. All that stuff is looked at. It's all objective. So that's the reason why we did it. But we realize it's been quite a few. And we can't get into a serious jam. So we opened, like I said, we opened up a ton, you know, like 40 or 50 in all the other areas and about 110 positions for nursing. that makes any sense. It's
Yeah.
all based on objective budgetary decisions.
Makes sense.
Sure. Anything else before I head out? Hopefully this was sort of interesting. I know it's a lot. I sped through it all, but
Yeah.
I think it was good enough. Hopefully. All right, thank you so much. Happy holidays too. Thank you very much.
You guys found it helpful. The QR code is up there. I also dropped the link in the chat, so whatever is easier for you guys to do. And again, thank you for your attention. Hope you found it helpful.
I have a friend who's a nurse and she asked me that question about the positions. I was like, well, I'm glad you're not in the class. That's always they're always the tricky ones for me is positions and my coworker, Megan Scanlon, my coworker, she does capital, so she gets hit with capital like all the time. Like, where's the capital? I don't understand.